Good morning. Welcome everyone as we start coming into the webinar for today about the pre-implementation performance reports. We'll get started in about a minute or so. Let everyone come in and we'll get started right at noon, East Coast time. All right, we still have a couple more folks coming in, and I know it's noon, so we'll give them a few seconds more, and then we'll get started. I know we only have 30 minutes. We have a good amount of information to cover in that time frame. So welcome everyone. Thank you for joining us at SimiTree to review the pre-implementation reports. My name is Charlie Breznicky, one of the directors on the clinical operations team. And over the next half hour, we're going to be going over the PIPR reports, which are the pre-implementation performance reports, what they are, where to get them, and really the main thing is how to use them as your agency prepares and moves through 2023, which is our first live year for home health value-based purchasing. So the basics behind the PIPR reports. CMS is providing them really for agencies to use as a tool to really gauge their performance on the VBP measures. So they're going to be released. You can see in the table up below, the first one was released November 2022. The second one that came out last week in January, and then the third one will be released in April. After that, we'll be moving into what they're calling the interim performance reports. They won't be the pre-implementation ones, but moving into July, we'll get the actual report, the first one to really give a better idea of how you're performing in the first full year of VBP. So if you have not already, I recommend that you go on to iKeys. The link is here. We'll be able to share this out. Pull down your PIPR report. It'll be helpful to have a look at that after I go through everything here, but they really are a great tool to use to see where you stand and where you can improve. Couple of things to keep in mind here. The data period for each of these is going to change. So the initial release in November, the OASIS-based measures went from July 1st, 2021 to June the 30th, 2022. There is a cool question about the slides. We will make handouts available and make sure that they are going out to everyone. So the time periods for the November was the 12 months ending June the 30th, 2022. For the OASIS-based measures, for the claims-based and the HCAPs, it was the 12 months ending March the 31st, 2022. So we had 3 months of the baseline year in there. In January, we had the 12 months ending in September for the OASIS-based and the 12 months ending June for the claims and the HCAPs survey-based ones. So a lot more of the data in there. And I'll go through how the numbers had changed from the initial release for the November one to January. But just keep in mind when you're having a look at these reports, the data period under review. So with that said, let's just hop into what the report looks like. So when you pull it down, it's an Excel spreadsheet. There will be a series of tabs at the bottom. The first one is an overview, which is fine. It gives an overview of what the PIPR is. But the next tab is the measure of performance one, and that's really the key one here, because it'll give your data and it'll look a lot like what you see on this screen. And we're going to walk through a lot of these points here and break this down to see how to use this, because when you're looking at these numbers, it can be a bit overwhelming and not really being sure where to look first. So once you get the report, the first thing to have a look at is just to validate the performance here. This way you'll know when you're looking at your data, if you put some initiatives in place that maybe haven't been reflected yet. So there's another question, will there always be a disconnect between the OASIS and the HCAHPS, or will the July IPR finally align the timing of each of these? They should align each of these because as we get through to that April report, we'll have the OASIS ones, but the claims-based and the HCAHPS ones should have caught up by that point. So as you can see here in this report, we have our OASIS base ended 9/30/22 with the claims and the survey based ended June 30th. So for the OASIS based, we're looking at 3 of the 4 quarters in that baseline year. Most of the data is already there. So the achievement threshold, the mean of the 90th percentile, is not going to change much. At least we don't expect it to. It did not change much from the November release to the January one, and it's unlikely to change a lot more in that April one. For the claims based and the survey based, we have 6 months of the baseline year data in there, so half of that data. Again, not much is expected to change there. So just have a look at this so you know what's happening here, what data is under review. So the next area that we want to have a look at is your percentile ranking. I skipped over the performance year measure, which is how you actually scored, and there is a reason behind that. The main thing is that's just a point in time. The percentile ranking, it kind of takes how you performed and compares it to everybody else and gives a quick, dirty snapshot of where do you want to improve. Higher scores are better here. As you can see in the discharge to community, this agency scored better than the 75th percentile. However, an improvement in dyspnea, they were in the 50th to the 74th. And then when we look at their acute care hospitalizations, they're less than the 25th percentile. So looking at this right after you just validate the performance year data, is important to know, okay, where am I weak? Where am I strong? Where do I need to focus to dive in a bit more and set some goals there or educate my staff? So to the right, you'll see where all the arrows had just dropped. You'll see the buckets of the percentiles. The 25th, the 50th, the 75th, and the mean of the top decile. So these are important to know here because you want to know how far are you from the next bucket. This is really important for when you go to set goals is, is this really out of reach? For example, if we're looking at in the improvement in the management of oral meds, you can see that 25th percentile scores at a 69.951. The 50th percentile is 80.294. So if I'm just above that 25th percentile at 70%, well, I need to look at this. Am I going to gain 10 percentage points over the rest of the year to get to the 50th percentile? Maybe, maybe not. That is a big gap to cover in a year. But it is important then just having a look at that to know where can I set realistic goals. Some agencies have set it wherever they are, they automatically set the next percentile above that. So if they're between the 25th and the 50th, they set their first goal is to be at the 50th, and then they'll set a goal for the next year to be at the 75th. So it's just a really helpful tool to see where can I measure and focus, what are the mileposts I can use as I go throughout the year. So the percentiles are really important also because the 50th percentile and the mean of the top decile are the biggest ones. If we remember in VBP, going back to the basics of it, is there's two ways to score points. You can get an improvement score, which is you in the end of 23 compared against how you performed in 22. If you improved against yourself from 22 to 23, you're going to get points. However, there's also the achievement threshold. So that is you compared against everybody else, your achievement score. And CMS has said the 50th percentile is the preliminary achievement threshold, and the mean of the top decile is the preliminary benchmark. Now, when you're having a look at your PIPR reports, if you're seeing in that percentile range, everything is in the 50th to the 74th or greater than the 75th, great. You're going to get some achievement points. That doesn't mean that the work is done, because you can still move up within that. On the other side, if you're looking at your report and you're seeing a bunch of scores in less than the 25th or the 25th to the 49th, that is not that doesn't mean you're not going to score any points. It may be harder to get the achievement scores. However, you can still improve against yourself and get improvement points. But what we're going to walk through for the rest of this for about the next 20 minutes or so is really how to use this, what it means, and how to use this to estimate your achievement scores. Before we get all into that, I do want to walk through a bit to see where the data had changed. But just to wrap up on this report, the last thing to have a look at is your performance score. So this is how you actually performed. So far, we validated the performance year. We looked at our percentile ranking, and then we looked at each of those buckets. What do we need to cross to get to the next one? This is where you look at then your performance year and say, okay, for improvement in dyspnea, my score is 87.148. That's a good score. It puts you in the 50th to the 74th. You say, okay, I wanted to set a goal. How do I advance? And we can just pick a number that we want to get 290, but we can use what CMS has provided here to say, how do we get into that 75th percentile? Use that data point there. And what they've said then is this is at 91.637. So we can set that goal for improving in dyspnea to go from 87.1 to a 91.6 and then beyond if we so choose. It's also helpful to know for those that are below, where do I need to get any points at all on the achievement score? If we look at acute care hospitalizations, this agency had a 16.1224. Well, to get to that achievement threshold and get any points, they need to get that rate down to a 13.76. That's a pretty hard goal. It's like almost 2.5 percentage points that you need to move. So that could be a stretch goal, could be a very challenging goal, but you want to set mileposts along the way. That the first one, it might be set to that 25th percentile, and then you do a midpoint between the 25th and the 50th, and then a 50th is like really a big goal that you want to get to. And if you can hit that, you'll get a little bit of achievement points, but you will get a lot of the improvement points because you scored really well against yourself. So when you get your PIPR reports, this is how it will look, so that you're at least aware of it when you get into that, having a look at that. Another thing that CMS provided in the January release, as opposed to the November release, was the achievement, the preliminary achievement thresholds and the benchmarks per cohort. So if you're a smaller agency, if you're going to be in that small volume cohort, remember that is 59 or fewer unique beneficiaries in your calendar year. So that'll automatically have you in that small volume. You don't do the surveys, the HCAPs aren't included, all the items are re-weighted. And you can see there is a different threshold that must be met on each one. So for example, a discharge to community, you only have to hit 66.77 as that achievement threshold, and an 88.219 though is your benchmark to be above that. When we look at that same measure for the large volume, we're looking at a 72.734 to get to that achievement threshold. So you have to score 6 percentage points better if you're in that large volume cohort compared to the small volume one to get any points. But when we look at the benchmark, which is that 90th percentile, that's only an 84.392. So it's a much narrower gap there. So there's some of the scores that might be a bit lower for that threshold in the small volume, but larger on a benchmark, and then vice versa on the large one. So depending on if you're a small or large, you can simply just have a look at this, see what your scores likely will be, and set goals on those if you so choose. So over the next few slides, I want to go through how things had changed from the November release compared to the January release. And then also, if there's anyone on this who is in one of the 9 model states, how things had changed from the scores then in the model, because those scores were based on 2015 data, to where they are likely to end up as we get into VBP and what the baseline year will be. So the first ones to have a look at are the 2 claim-based measures. So really having a look here, you can see that scoring better than a 13.76 in January and a 13.81 for November would have gotten you some points. So you can see there is not much of a change from the November release to the January release. And we now have 6 months of the data for the claims-based measures. So there are several questions coming in. I will get to these as we go through these. I will save time at the end to answer those. If there's any other comments, put them in the chat Q&A, and I will answer them before the time is up. So in the acute care hospitalization, you can also see in the model that agencies that may have scored maybe at a 14%, they got some points. But if you're scoring at a 14% still, you're not even going to be better than that achievement threshold. So even though an agency was part of the model and scored pretty well, they still will have room to improve in some of the measures. The same goes for ED without hospitalization. And you can even see there was significant variation between the states. Florida had an achievement threshold of 10.11%, whereas Massachusetts had 12.83%. So it wasn't even in that model because all the states would just compete against everyone else in that state. But when we look at things on a more national scale, you can see that data, it smooths out a little bit more. When we get into the discharge to community score, this is one of the questions. The OASIS item is M2420, asking where the patient goes at a discharge. So that one is asking if it's a score to 1 or 2, it is a positive score. So the numerator and the denominator for the discharge to community measure, this would be any patient that did not end up into the hospital, or any patient that did not, the denominator exclusion is all patients except for those that died on the service. The numerator, so those that count positively towards you, is anyone that is scored as a 1 or a 2 on the discharge to community score. And as far as the, there was a question about if observation visits are counted in the ED without hospitalization item. So those are claims based. If the patient is in the ED submits a claim and the patient is not hospitalized, then it would be an ED without hospitalization. Now, if that patient is admitted at a later time within the first 60 days, they will only count in the acute care hospitalization score. So you can't get dinged on acute care hospitalization and ED without hospitalization item. It's a one or the other. If the patient is in there. So when we look at the discharge to the community score, you see there's not much of a difference there. And dyspnea scores, this is one that really wanted to stress because there's another one. We look at this in Massachusetts, and the benchmark score, so the top 10% was an 82.06. So an agency could have scored 83% and performed very well in Massachusetts. They would have got the maximum amount of points. However, that same 83% would not get them any points in the new calculations. So even those agencies that went through VBP before performed well, that is no guarantee they're going to perform well again in this one. So it's really important, if you are a model state, don't just rely on the reports that were released in 21 to show how you did. Look at the PIPR report to see what are the targets that you need to hit now. When we look again at the more of the OASIS-based, management of oral meds is another one, a similar one, a bit of a wider gap. 72% was that score that had to be hit to get the maximum amount of points in Massachusetts. And we look again at the January release of the PIPR, 80.29. So you're looking at 8 percentage points almost that you had to improve to get those points. That's a big gap there to actually improve there. The total and normalized composite scores, we have the self-care and the mobility. The self-care scores, you're always going to get more points simply because there's more items in there. There's 6 in there versus there's only 3 in mobility. But you can see, even in the model states, there is improvement required, that each of the thresholds do need to be higher. You do need to score a bit better to get any points in VBP as we're getting through the baseline. Through 2023, the baseline year will likely be higher. As we get into the age caps items, so one of the questions came up was, what happens to the age caps measures if an agency does not have enough patients responding to the survey or has no measurable scores? That is a great question. CMS has indicated there are minimum criteria that must be met. So for the OASIS-based and the claims-based measures, there must be at least 20 of those. So 20 OASIS, 20 claims to get points on those. For the age caps, you have to have a minimum of 40. So if you're an agency that is just over the small volume, so let's just say you have 70 patients, is your unduplicated census in a year, you have to have 40 responses for the surveys to get scores in those. If not, all the items will be reweighted. So it's really important in the age caps, stressing with the patients, asking them to respond that. If you have a low response rate, try to get that up. And then stressing to them, it's important to fill out the entire survey because you want to get them to answer all of the questions that impact VBP. So when we get in here and we look at the survey-based ones, there is not as much of a change here. Part of this may be that in the 5th annual report that CMS released on the VBP, the model was survey scores actually, there was no significant improvement or they declined. So which makes sense that we're not going to see much of a change on the survey ones. You can see the care of patients, some change here. We're looking at Florida, the benchmark was a 95.72. We're looking at the benchmark for January was a 94.39, and all the way across the board for the achievement thresholds was 88.75, with the highest one being we're looking at an 89.03. So not much of a change there in the survey items. So when we look at the care issues, this is the third of the composite items. Again, similar trends. The gap between the threshold and the benchmarks have actually widened. So there is a bit more room to get some more points there. And you can see the thresholds actually dropped compared to the model states in this measure. When we look at the overall ratings, so this is agencies that score a 10 on the survey. A little bit higher here for each of these. Looking at Florida, we're at 84.27, Massachusetts 85.74, which kind of is right in line with what the January release showed of 85.63. So if you were getting some points in the surveys in a model state, you're likely to get some points again if there's not much of a change. So the next piece that I want to move on to is really how do you use the PIPR report to get your scores? So there is a lot happening on this slide, and I'll walk through it all. So that top calculation is really just a reminder as to how do you get the achievement points. All of the variables that you need to score this are going to be included in the PIPR report, and I'll show you that on the next slide. But just that formula, it's your performance score minus the achievement threshold, which will be that 50th percentile, divided by the benchmark, which is the mean of the top decile, minus the achievement threshold. Multiply that by 10, that's your achievement care points. Now, all of the OASIS items are weighted as well. So to get that weighted measure, the table at the bottom gives the 3 different types of the measures, the claims, OASIS, and the HCAHPS. The measure name, the points available, the OASIS and the claims give you a 35 potential points, HCAHPS 30. The measure column is their weighting within that category, but the TPS is the weight that you'll use to calculate that weighted measure. So you'll take your care points, which we identified in the formula above. We divide that by the maximum possible care points, which is always at 10, multiplied by the measure weight to get the weighted measure points. So let's look at a scenario of this. We have the discharge to community. Performance here, we scored a 78.17. The preliminary achievement threshold is a 72.734. The benchmark preliminary is an 84.392. We have our weighting down below of a 5.83. So let's plug these numbers in here. We have the 71.87 minus the 72.734. We divide that by 84.392 minus the 72.734. Multiply that by 10, we get a 4.663. That's the achievement points. And remember, that's on a scale of 0 points, which is none, up to 10 possible points. The improvement formula is very similar, except you take the improvement thresholds and you multiply it by 10 rather than you take the improvement threshold rather than achievement threshold, and you multiply by 9 as opposed to 10. So we have our achievement care points. We now have to apply a weighting onto this one. So we take our care points, which is the 4.663, divide that by the maximum possible, which is at 10, multiply that by 5.83, which is the weighting, and we're going to get 2.718. That is the amount of points that we're going to get in this measure. Now, it doesn't seem like that's that much when you're looking at up to 100 points. But the maximum you could get on this score, the discharge to community, is 5.83. And you're getting close to half of that, 2.718. So this is helpful also when we look on our next slide here. You can run this calculation for the entire PIPR report and see where you score, add it all up, and you'll get a total performance score at the bottom. So anything that is scoring low, like 0, are the areas you want to focus on. In this case, this agency's acute care hospitalizations yielded them 0 points. This one is the most heavily awaited one, has a potential of 26.225, and they didn't get any points at all from that one. So it's really important. They want to have a look at the acute care hospitalizations. So again, these are measures. If you're running this, you're having a look at it. Look at the achievement points, but then what are your low performing total performance score points to see where to focus efforts. The 33.87, it's impossible to tell right now if that is going to be a positive or a negative payment adjustment, but the higher the score, the better. So if this agency is able to get 10 points even from acute care hospitalizations, they'll bump that score up to a 43.8 to 7. So really it helps you there. Where are you likely to perform? So just want to put together a summary here some of the key points. First thing, go into iKeys, pull down that PIPR report. Look at your percentile ranking. The lower ones are the areas you'll want to focus on. Look at your performance shared values, how far, and then you're able to calculate the total performance score using the formula that was on a few slides ago, and it was also provided by CMS. Once you've had a look at that total performance score, you want to establish goals. Where do you want to get to that next threshold? How do you improve? Once those are in place, you want to put in a plan for improvement, and then of course monitor your progress, share the results with your staff, and continuously evaluate it. So I'll get to the questions now. Option 3 at a hospice to home, and option 4 left the geographic area count in the negative. Option 3 will count in a negative. I reached out to CMS a while ago and did confirm that. They said that will count as a negative. Option 4, I will look into that and I will confirm that. That might be an exclusion. I will see about that one. The next question was, if a patient who has been discharged from a same-day surgery from a hospital post-ortho, like a knee replacement, considered as acute care DC referral. That would depend on their admission status. And that's probably closer to, are they institutional or the community? Because if they're going back into the hospital, we'd have to see how they're billing that claim, and we can have a look at that and follow up on that one. The next one asks about if our staff are documenting they are discharging patients to outpatient PT, does this impact our discharge to community? So it should not, because they're going to be a discharge to the community, and the questions are with or without formal assistive services. If they're going to outpatient PT, that will be with the formal assistive services. Is the determination of the smaller versus the larger volume based on the survey responses or claims based? So the cohorts are based solely on your census from 22. So however you ended in 22 will put you automatically in the small or the larger volume cohort. The PIPR does not have the TPS or rank provided. That is correct. That last slide that I had showed with the TPS score here, this is one that we have created at SimiTree to calculate it out. It will not be on the PIPR report, but you can use all of the variables they gave you to get these scores. We will be sending out these slides, so they are available. If the patient goes to the hospital multiple times in one episode, does each hospitalization count? No, it's just once. So it's just one acute care hospitalization. So if they go in 3 times, that'll count against you 1 time. And then is the total performance score points included in the PIPE report? Again, it's not. This is a formula that we created using the variables and the formulas that CMS provided. If there are any other questions that I did not get to or that you did not think to ask, feel free to reach out. Our phone number is up here. Website is here. Feel free to reach out with any questions. We are happy to help out. Can we view a simulated PIPR through SHP? SHP has their VBP national preview report. It's not a PIPR report. They have their own metrics with percentiles. So it's not exactly the same, but similar. I'm not sure if they've updated the threshold yet to 2022 data or they're still using 2019. Do you recommend calculating both the achievement points and the improvement points? So the achievement points you can estimate at this time. To get the improvement points, you have to know how you finished 2022, which you can have that if you go into, if you have software that allows you to do that. Someone had said SHP before, you can head in there, pull that down. How did you end 2022? But to put in how you're performing now, if you just put in the 2022 data, you're not going to see a change. Everything is going to be a 0 because you didn't improve against yourself. However, if you pull your 2022 data, you can then pull January data to see how you did in that month. Granted, it's just 1 month, but you can trend that over the whole year to see if you've improved. I would give, if I was doing this now, I would give at least the first quarter to begin to calculate my improvement points, because it gives me that 3 months of the data in 2023 compared against how I ended 2022. So someone had confirmed SHIP is still showing the 2019 data. Question to clarify the discharge to the outpatient desk services, would that be the discharge with the formal assistive? Yes, that should be a discharge with the formal assistive services. I will confirm that and follow up on that question. I just want to say thank you to everyone for taking the time to join today. Question about the cohorts, is the cohort grouping based on total completed surveys? No, the cohort is based on the census. During OASIS, we were told that 2420 DC2 community and guidance has changed. I will have a look into that and follow up with you about that, because CMS had said if they're going to a hospice, that it would be a negative. I did have that as an email from CMS when I asked them about that. Thank you again, everyone. I hope this was helpful. If there's any additional questions, please feel free to reach out at the phone number or the website here. Thank you very much. I hope you have a great day.